estimated 2.5% after 75 years of age. A 60-year-old female came with fever and dysuria since Monday. She was referred to us with hand cellulitis as a diagnosis. There were multiple swellings over the MCP joints, as you can see in this picture. And the swelling soon started secreting a chalky white material since the 15 days. After biochemistry, we found she had an acute kidney injury with an underlying chronic kidney disease, a high uric acid levels, and she required hyperuricemia. As you can see in this X-ray, there is a soft tissue swelling around it, but the tophi are not very prominent. So the tophi are usually translucent, radiolucent. Only when they get calcified, they are seen in the X-ray as radio-opaque. There's another 62-year-old female, high BMI, pain in hand joints. There are nodular swellings over the PIP joints, as you can see. She looked like gout because high HbA1c, high uric acid, metabolic syndrome, along with high creatinine. But when you get nodular swellings like that over the interphalangeal joints, do think of other differential diagnoses also, like rheumatoid arthritis nodules, methotrexate-induced nodulosis, besides tophi, also multicentric reticulohistiocytosis. And for this, besides history, laboratory, X-ray, ultrasound is useful. Aspiration and biopsy may be required and support your diagnosis. Another 56-year-old female, obese, ankle foot swelling, a chalky white discharge, high PSL, high HbA1c, and high creatinine. Let's look at this history. 26-year-old female, 28 weeks pregnant. Blood pressure is high, there is proteinuria, a little high blood sugar. Obviously, she is got preeclampsia and high blood sugar. Uric acid is 8. So what do we do about this? Do we treat or we do not? We do not, because pregnancy levels are interrelated. In the first trimester, there's a fall in uric acid level because of the glucosidic effect of estrogen. But later on, uric acid levels start increasing, and there is a strong correlation with patients with preeclampsia. Hyperuricemia by itself has risk to the mother and the baby both, but no hyperuricemic drug should be used in isolated hyperuricemia. This is about effect on the fetus and the placenta. Uric acid inhibits trophoblast migration and causes oxidative stress and inflammation. It can inhibit fetal angiogenesis, inhibit endothelial function, induce oxidative stress, increase blood pressure and systemic blood pressure, and induce insulin resistance. So, gout in pregnancy is rare, though hyperuricemia may be there. Rare flares can occur in third trimester. So we should check the other factors like creatinine, evidence of insulin resistance, etc. But we should only give short course of steroids in cases of acute flare. Probenecid may be tried. You can give intra-articular steroid injection and hydrate the patient adequately. But for majority of patients, as you all will know, we are dealing with a metabolic syndrome, which has been dealt by Dr. Ashwini very well. So hyperuricemia can be a part of the metabolic syndrome in most of our patients. So we have to screen the other organs. Do not rush to give allopurinol or tapixostat. We all are aware of the definition of the metabolic syndrome: high blood glucose, low HDL, high triglyceride, increased waist circumference, and blood pressure. So excessive weight, dietary choices as of today play a vital role in metabolic syndrome in raising the uric acid levels also, consuming food, electric urines, etc. There's a direct correlation between the abdominal fat and hyperuricemia. So there was this lipidemia, chronic heart disease, peripheral arterial disease, diabetes, and urine insufficiency as compared to males with gout. Often they have upper limb polyarthritis against the classical podagra or the first MPP joint gout. Also, females with PCOD, polycystic ovarian syndrome, are also known. So patients with hyperuricemia are at higher cardiovascular and renal comorbidities in females with gout. And also in polycystic ovarian syndrome, there is a high prevalence of hyperuricemia and reproductive hormones. So what about diagnosis? The gold standard remains synovial fluid analysis. As you can see in this, there are yellowish colored crystals with a negatively bright birefringent, which appear yellow when the rays are parallel to the crystals. On X-ray, you can see the joint space is preserved till the last. You may have tophi, if they are calcified, they can be seen. Then you get erosion because of the tophi. These are like punched out erosions of the bone, overhanging or rat bite appearance of the cortex. Most important is ultrasound because the DC sign is a very useful sign when you're not sure, especially in ankle joint arthritis. As you can see, this is the bone and this is the cartilage with the deposition of the urate crystals, which gives you the double DC sign or the double contour sign. Sometimes the urate crystal shows no strong appearance, as you can see in this slide. And here is an intra-articular focus. So all of them show the DC sign very well. This is a 38-year-old female, recently visited our OPD. She had diagnosed with a dilated cardiomyopathy. She also had arrhythmogenic right ventricular dysplasia with autosomal dominant polycystic kidney disease. She has been treated for this heart failure with torsemide, valsartan, etc. She presented with right ankle pain, both bilateral ankle pain and swelling, more in the right, which was very painful. Uric acid of 10.2. So we omitted the torsemide and we replaced with indapamide, which is slightly, slightly better when it comes to uric acid levels. Fortunately, she responded to NSAIDs and the swelling and the pain is subsided. This was her ultrasound. You can see over here the double contour sign. So in this patient, it becomes tricky because we can't really omit the diuretics. So we can go with other agents. DCT profile, DCT scan, dual energy computed tomography is a new imaging modality. The green lesions are signs of the profile, which can help you when there's no synovial fluid to aspirate. Management, all of you know, acute NSAIDs, corticosteroids, colchicine. Peptidoglycan and allopurinol should be added a little later for maintaining stability. But most important is lifestyle modification, diet, weight loss, correct the underlying cause, and there is no evidence to just treat asymptomatic hyperuricemia. Avoid red meat, avoid alcohol, avoid seafood like prawns or shellfish. And out of the alcohol, again, beer is the most important for causing high uric acid levels. Out of the precipitating drugs for gout, mainly diuretics, antituberculous medication like pyrazinamide and ethambutol, and there's a long list which you should keep referring to when the patient comes with a high uric acid. So, urate-loading therapy is recommended when there are 2 or more attacks of gout per year, when the presence of tophaceous gout, chronic kidney disease. More and more of these patients are visiting now because they're available of maintenance hemodialysis, and when there are renal stones. First line of management is with allopurinol and peptidoglycan. Allopurinol is cheaper, but only you have to take care of the hypersensitivity or scars, which can be quite devastating. Peptidoglycan and topiroxostat is come, which can be used. Mucoceles can be used, like we have probenecid only, which is available in certain situations. New drug like pegloticase is a very good drug for chronic tophaceous gout. And it is really, it sort of dissolves the tophi, but it's very expensive. In the United States, it's cost $25,000, and we have to give it every 2 to 4 weeks IV. So it is being used there with the insurance covers, but really is beyond our league at present. Out of the other newer drugs, we have lesinuride and you have tranilast, which you should know about, but is still not available. So take-home messages. Gout, though uncommon, can occur in females. It is often polyarticular, not just the classical podagra which you see in males. Most of the time post-menopausal, a part of metabolic syndrome. Most of our patients have renal dysfunction, so you should check the creatinine. And hyperuricemia by itself is a risk factor more in females than males for chronic cardiac disease. So when you compare men and women here, men with gout are younger, often have lower limb predominance, foot, ankle, have oligoarthritis. With women have often an atypical presentation, older, post-menopausal, may have upper limb involvement like a patient we saw, and is often a polyarticular gout. Thank you.
So excellent overview of gout in females and the differences between male and female. Obviously, our therapy remains through allopurinol and peptidoglycan. Predominantly, hardly we use glucosilic drugs and uricase inhibitors. But excellent overview. Short of time, we won't be taking questions now. We go ahead with the next session.
Thank you, ma'am. We request the chairpersons to kindly felicitate, ma'am. I would like to call upon the chairpersons for the next session. The topic is pregnancy and APS and enigma. The chairpersons are Dr. Vandana Nimbargi, ma'am, and Dr. Ajit Nalawade, sir. Dr. Vandana ma'am is a professor at the Department of Obs and Gynae in Bharati Vidyapeeth, Pune. And Dr. Narave sir is a senior rheumatologist. He heads the Focus Arthritis Foundation. Yes, sir. To deliver her talk, I would like to now call upon a very eminent rheumatologist in this country, Dr. Rajeshwari ma'am.
I'd like to welcome you all to this ultimate session. And it's an immense pleasure to invite Dr. S. Rajeshwari to give us the talk. She is professor and head of the department at Sri Ramchandra Medical College in Chennai. And she has been the past professor and head of the department at Madras Medical College as well as government Medical College in Chennai. She'll be talking about antiphospholipid syndrome, enigma, in fact, which is basically something difficult to understand and difficult to explain. With your talk, ma'am, probably it won't remain an enigma anymore. Thank you.
I think it will become more of an enigma. Okay. Thank you very much for your kind introduction, sir. At the outset, I would like to thank the organizers, the Vidyapeeth group, and all the women, and also all the men in this group here. I'm honored to be here. I came all the way just to honor women and all the things we've spoken about today. I think it's a very good move to dedicate something towards women in our country. And on this day, when we are celebrating Women's Day, International Women's Day, I'd like to be a small flower which will add to the fragrance of the variety everywhere. And all of you should know that a very small flower called mimosa is the flower of International Women's Day, and the color of the flower is lilac. So that is how the color of International Women's Day came about. Now we'll go to another enigmatic and a big problem, which is as colorful but not so colorful to treat. That is antiphospholipid syndrome, and especially the obstetric complications are very, very many. And it's going to be a head-spinning talk. Let's hope we try to understand a little more about it. Pregnant pregnancy losses contribute to 1% of total pregnancies, of which antiphospholipid antibodies constitute 15%. They are a major treatable chunk. But with the new diagnostic modalities available, it can be treated quite easily. But however, it's a game on two lives. It is her tragedy and our challenges. In this talk, it will be an overview about the definition, pathogenesis, concentrating more on the obstetric manifestations, a little bit about the diagnosis, management, a very little portion about refractory APS and the summary. So what is antiphospholipid antibody syndrome? It's a disorder of recurrent vascular thrombosis, as all of us know, and or pregnancy-related losses, which is associated with persistently elevated levels of antiphospholipid antibodies. Please remember this term. It's a very important term, what we mean by persistently elevated. Transiently elevated levels do not really need treatment. So that is why every word is important in the definition. Now it can be primary or secondary. Primary constitutes 50%, and secondary is mainly due to the connective tissue disorders about which all of us know. Main disease being SLE, followed by Sjogren, MCTP, rheumatoid, and progressive systemic sclerosis. Now, what are these antiphospholipid antibodies? They fall into four categories. Anticardiolipin antibodies, about which all of us know. The anti-2 beta-2 GP1 antibodies, which is very, very, very important because it's a cofactor which modulates the interaction between the phospholipid antigen and the antiphospholipid antibody. It is a natural anticoagulant. It's always called as ApoH also. Then we have the lupus anticoagulant, the most specific among all these antibodies. And if a single positive, persistent positive LAC is present, then it is good enough for us to call it antiphospholipid syndrome, and that demands treatment. And now we have the other antibodies. All of you would have heard about the term seronegative APLA. It is not seronegative at all. Things have changed now. Lot of advances are there in science, and we should know what is known, what is true, or what is going to be there in the future about seronegative APLA. What is the definition of that? Seronegative APLA means presence of antiphospholipid criteria manifestations, but they are negative for the regular APLA antibodies which we discussed about, and they have the non-criteria manifestations. Certain manifestations are not included in the APLA criteria, like thrombocytopenia, which was there before but has been removed now, the libido reticularis, the neurological deficits, etc., etc., etc. Now you see the number of antibodies which are present, which we're not screening properly at all, and we don't screen in many centers. They all start with phosphatidyl. So it will be ethanolamine, serine, phosphatidic acid, and inositol. All these are related with pregnancy complications. Then we have the vimentin. The vimentin gets clubbed with the cardiolipin, forming a cardiolipin-vimentin complex, which again is very important for fatty liver events. Then we have the annexin 5. Annexin 5 is the most important antibody associated with pregnancy losses. And of course the beta-2-GP1. It would be nice if we can recap the coagulation pathway. All of us know. It's not working. We know the intrinsic pathway and we know the extrinsic pathway. Both of them converge at factor 10, which gets activated. It's at the level of this factor 10 that the phospholipid template is present, and the presence of calcium and factor 5 also gets activated. Thereafter, the coagulation pathway starts working, and we have the prothrombin, which gets activated to thrombin, then fibrinogen, fibrin, and the single fibrin clot. We have the extrinsic pathway, that is phosphate tissue damage. So all these are, and then the factor 8. So many of these factors play a role in the presence of formation of natural clotting of the coagulation pathway. When this doesn't work, and when antiphospholipid antibodies are formed against the phospholipids, this pathway gets disrupted. And this is a recap about we have not only antibodies to the phospholipids, but we have antibodies to what are called as phospholipid binding proteins, about which this beta-2-glycoprotein 1 is a binding protein. It is like a sandwich. The beta-2-glycoprotein is situated between the phospholipid membrane below and the antibody above. It is sandwiched in between. So it has to get activated for the antibody to get attached to the phospholipid. Only in the presence of this does this mechanism work. Among the phospholipid binding proteins, we have the annexin 5, protein C, protein S, which are very important, and also so many other components. See, it has been thought that this phospholipid anti-APLA syndrome is only a vasculopathy. It is not at all a vasculopathy. It is a pure inflammatory phenomenon in the initial stage. Later on, only the thrombosis and everything occurs. So when you have an inflammation, obviously complement has to play a role, and then other cytokines, about which I'll be talking very shortly. I won't confuse you a lot. A lot of cytokines play a role. The innate immunity comes into play. When all these occur, when the complement cascade is activated, when all these come into play, then the endothelial cells get activated. The cytotrophoblasts, sensitive trophoblasts, all of them play a role. And when all these mechanisms act together, the monocytes, and other cells, endothelial cells, all these get activated. All this is only due to inflammation. Then only the vasculopathy and the thrombosis event occurs. This is the structure of beta-2-glycoprotein. You can see there are 5 important domains. This is called as the sushi domain. The domain 1 is the important one, which gets attached to the antibody above. And below that, the white line you see is the phospholipid membrane. And in pregnancy, it's going to be the trophoblast membrane. So the trophoblast membrane is negatively charged, and the factor 5, domain 5 is positively charged. Naturally, unlike poles attract each other, they join together, and then the beta-2-glycoprotein gets activated and the antibody to the phospholipid comes to domain 1 and it gets attached, and thereby the complex is formed and the action of the antibody and the antigen-antibody complex occurs. For this, the phospholipids which are present in the membrane, this membrane, they have to get activated. Once they get activated, they flip out. Normally they're situated inside, they flip out of the membrane, and that is when they become negatively charged, and that is how the interaction occurs. Cardiolipin was the first antibody, the antigen to be discovered, which is present inside the inner membrane of the mitochondria. Now a little bit about beta-2-glycoprotein 1. It exists as a monomer, and then when it's activated, the factor 5, annexin 5, I'll show you in the next slide about annexin 5. When it gets activated, it becomes a dimer, and this dimerization is very important for all the other interactions to occur. It binds to annexin and the same for intracellular signaling starts. Whenever there is an positive intracellular signaling, inflammatory phenomenon occurs and all the cytokines are released. That is the antibody. Now the role of annexin 5. Annexin 5 is a protective anticoagulant which sits on the trophoblast layer. Now what happens when the beta-2-glycoprotein 1 starts acting over there? It interacts with this and then it displaces this annexin 5 from this membrane, thereby producing a procoagulant state. See? Then we have the other natural anticoagulants being inhibited, the protein C, protein S, and the antithrombin form. So all these play a role in the thrombosis. And here we have the anti-domain 1 which interferes with the platelet aggregation. Autoantibodies release the 1 milligram factor from the endothelium, and autoantibodies inhibit the RMPS. What is the function of RMPS? It is supposed to splice the long 1 milligram factor molecule. Once that is inhibited, this splicing does not occur, thereby platelet aggregation and the prothrombotic state occurs. This normal pregnancy, you can see the sensitive trophoblast here, you can see the central trophoblast. This goes and invades into the residua, thereby trying to fix the embryo over there. So all these functions are altered. This here you can see the residua, these are the trophoblasts, and these are the spiral arteries. So all of them, this is the maternal blood vessel, all of them are affected here by the anti-beta-2-GP1 antibodies which interact with the residual cells, the trophoblasts, which are introduce inhibition of the proliferation and differentiation, they reduce apoptosis, and the anti-phospholipid antibodies themselves produce placental thrombosis. They prevent the alteration of the spiral arteries, thereby preventing the natural flow in the blood vessels, and the beta-2-GP1 reacts with the residual cells, that is a pro-inflammatory phenotype. The role of toll receptor, when the beta-2-GP1 sits and interacts with the phospholipid and the complex is formed, that activates complement. As I already told you, when the C5a is activated, the membrane attack complex also is activated, that activates the cell. And then you have a whole series of events happening over there. You have the adhesion molecules which get upregulated. The C5a in turn again acts on the platelet, the TNF-alpha, the neutrophils, and nowadays next, the neutrophilic extracellular traps, the netosis, releasing oxygen-free radicals and damaging the tissue complexes. All those are new strategies that are involved in the pathogenesis of pregnancy-induced antiphospholipid, pregnancy-associated APLA. This is a very old slide, but a beautiful slide. You have to have two hits, the first hit and the second hit. Second hit is due to trauma, infection, and other factors which predisposes to the thrombosis formation.